Okay, so this video is being recorded in order to study for the advanced health assessment and reasoning class and the final exam for that class. This is just a bunch of index cards and I'm just going to go over them. I encourage you to push pause and try to answer the question if you want to do it that way. Otherwise, I'm just going to listen to myself explain these things repetitively. First one is list the examination findings for BPH, benign prostatic hypertrophy. They are asymmetry and nodules. These may indicate that there's a malignancy. You could have tenderness or enlargement, and that may indicate prostatitis. What are some examination findings for prostate cancer? Those include elevated PSA. The greater the elevation, the more likelihood of cancer. Abnormal digital rectal exam. Positive prostate biopsy. And usually these patients are asymptomatic. Positions for performing rectal exams. Can you name them? The knee to chest position. The lithotomy position they say is best for women. The left lateral with hips and knees flexed is best for men. Standing with the hips flexed and the upper body supported by the exam table is another option. What are some characteristics of menopausal disorder? Irregular frequency of monthly ovulation after the age of 40. This is a genetically determined disease process. It is unrelated to the age of menarche, how many pregnancies, or the type of contraceptives a person used. What are some menopausal symptoms? Hot flashes, disturbed sleep patterns like insomnia or fatigue, vaginal dryness, dyspareunia, which is painful sexual intercourse, and atrophic vaginitis. What are some characteristics of pelvic inflammatory disease? In the early stages of pelvic inflammatory disease, your patients are most likely going to be asymptomatic. Pelvic inflammatory disease is most often caused by chlamydia or gonorrhea. There's increased discharge and bleeding after intercourse. Intercourse causes bleeding, abdominal pain, fever, even vaginal discharge. The infection begins intravaginally and then spreads upward to cause salpingitis, infection of the fallopian tubes. And ectopic pregnancies for these patients are common. Examination findings for the patient with pelvic inflammatory disease include abdominal tenderness, cervical motion tenderness, adnexal tenderness, which is the ovaries or the fallopian tube area, guarding rebound tenderness, increased white blood cells or an increased sedimentation rate. You can have cultures that are positive, a grand stain that indicates something, DNA testing, and HIV testing are recommended. Characteristics of a hydrocele. Scrotal tenderness and swelling, sensation of heaviness in the scrotum, an inguinal hernia, soft, non-tender fullness within the hemiscrotum, and the transillumination of the scrotum reveals homogeneous glow without internal shadows. Characteristics of epididymitis. This is inflammation of the epididymitis. Epididymis, sorry. Fast onset of symptoms. You have urethral discharge, severe swelling of the scrotum, pain, high fever and rigors, nausea and vomiting, and irritative voiding symptoms such as frequency, urgency, and pain. Characteristics of epispadias. This is a congenital issue. It is when the urinary meatus is on the upper surface of the penis. Characteristics of hypospadias. This is also a congenital abnormality. This is when the urinary meatus is located under the surface of the penis. Some ethical considerations as an advanced practice RN include negligence, moral obligation, consent, patient autonomy, responsibility, liability, scarce resources, clinical governance, and research. Cardiac system inspection. What do we do on inspection of the cardiac system? Of course, you have to have tangential lighting for everything. Stand on the patient's right side, and the patient sits erect and leans forward, or they can be in the lateral recumbent position. The apical pulse is found the midclavicular line at the fifth intercostal space, and make sure that you're checking for cyanosis, venous distension, nail bed cyanosis, and capillary refill. Cardiac includes circulatory, don't forget. Cardiac system palpation. What do we palpate and how? The patient should be supine. We palpate the pericardium. We use the proximal forefingers or the whole hand. We begin at the apex of the heart and move inferior to the left sternal border, and then up the sternum to the base and down to the right sternal border. Apical pulse is at the point of maximal impulse, and feel that through. Use the other hand to palpate the carotid artery, one at a time. Cardiac system percussion. So, in percussion, we are going to try to define the borders of the heart and size it. We need to determine the size, but it is limited due to the rigidity of the chest. So, a chest x-ray will best define your border. Tap from anterior axillary line, moving toward the sternal border. We're going to find resonant sounds to dull, and when you find the dull, that's where the border is marked. Cardiac system auscultation. We want to listen to all 5 cardiac areas using first the diaphragm and then the bell. Firm pressure is used with the diaphragm. Light pressure is used with the bell. The 5 cardiac areas include aortic valve, pulmonic valve, the second pulmonic, which is also Erb's point, tricuspid valve, and mitral valve. The steps include We want to assess the rate and rhythm of the heart. We want the patient to breathe normal and hold on expiration. Then we want to listen to S1 while palpating the carotid pulse so that we can compare. Then inhale deeply and listen for the S2 during inspiration. The things we're looking for when we listen to the basic heart sounds are pitch, intensity, duration, and timing. The 4 basic heart sounds are S1, S2, S3, and S4. What are 3 types of chest retractions or deformities that are often seen with chronic conditions? Those are pigeon chest, funnel chest, and barrel chest. What measurement of the chest indicates a chronic condition is present? When the anterior-posterior diameter is less than the lateral diameter. What is the normal respiratory rate? And what is the respiration to heartbeat ratio? The normal respiratory rate is 12 to 20 breaths per minute in adults, and the normal ratio is 1 breath to every 4 heartbeats. Okay, so define some terms. Define tachypnea, define Kussmaul's respirations, and define Cheyne-Stokes respirations. So tachypnea is rapid breathing. Kussmaul's respirations are deep and rapid. And then Cheyne-Stokes respirations are regular periods of breathing with intervals of apnea, followed by a crescendo and decrescendo sequence of respiration. Define. So what are retractions? Retractions are seen when the chest wall seems to cave in at the sternum. Define crepitus. Crepitus is both palpable and audible in some cases. It is a gentle bubble filling or a grating vibrational filling. How do you palpate for thoracic expansion? First, we're going to stand behind the patient and place our thumbs along the spinal process of the 10th rib. Our palms are going to be slightly touching each other. Our thumbs move away as the patient quietly and deeply breathes. What is tactile fremitus, and how do you palpate it? Tactile fremitus is the palpable vibration of the chest wall that occurs from speech. You need to feel it posteriorly. Your patient says 99 or Mickey Mouse. You palpate simultaneously and symmetrically. Increased fremitus can equal fluid or a mass. Decreased fremitus can equal excess air in the lungs. What do you palpate the chest to feel? So when we're palpating the chest, we want to look for pulsations, tenderness, bulges, depressions, masses, or unusual movement. What is a pleural friction rub? Pleural friction rub is a grating, coarse vibration on inspiration. Percussion of the chest. What do we look at? And what are the steps of percussion? So when we percuss the chest, we are looking at diaphragmatic excursion, percussion, tone, intensity, pitch, duration, and quality. We tap sharply from the wrist, examine the patient's back while sitting, his head bent forward, and arms folded in the front. The patient raises his arms overhead while percussing in the lateral lung or the anterior chest. How would you describe the sound heard over a healthy lung field? What causes hyperresonance? What causes dullness or flatness? So I would expect to find resonance over lung tissue. Hyperresonance can indicate hyperinflation, which occurs with emphysema and asthma. Dullness and flatness over a lung field could indicate pneumonia or atelectasis. What is diaphragmatic excursion, and what are the steps to test this? Diaphragmatic excursion is movement of the thoracic diaphragm during inhalation and exhalation. How you do it is you have the patient take a breath. You percuss the scapular line locating the border of the lung and mark that point. Then repeat on the other side. You have the patient take a deep breath and hold that breath, and then repeat up from the marked point until resonance is heard. Repeat on the other side. The usual distance for this is 3 to 5 centimeters. In an adult, of course. That's diaphragmatic excursion. Okay, so when you are auscultating your respiratory system, what are you looking for? First of all, we're going to use the diaphragm. We're going to go from the apex to the base of the lungs and compare the sides to each other. We're listening for intensity, pitch, duration, quality of breath sounds, adventitious breath sounds, and vocal resonance. The patient should be sitting up and breathing slowly. What are normal breath sounds? What are adventitious breath sounds? Normal breath sounds include vesicular, bronchovesicular, and bronchial breath sounds. Abnormal or adventitious breath sounds are crackles, rhonchi, wheezes, and a pleural friction rub. How do you palpate the peripheral arteries? Remember, it's one carotid at a time. Palpating both carotids simultaneously can cause the patient to pass out. We need to palpate at least one pulse per extremity, and usually the most distal pulse. We can do the Allen test, and we can assess heart rate, rhythm, pulse control, amplitude, symmetry, obstructions to blood flow by assessing your pulse points. So where do you check the peripheral arteries? Those spots are carotid, brachial, radial, femoral, popliteal, dorsalis pedis, and posterior tibial. What is clubbing? Clubbing is enlargement of the terminal phalanges of the fingers or toes. Clubbing can be seen in emphysema, lung cancer, cystic fibrosis, or congenital heart disease. allele nasi flaring is a sign of what? Air hunger. What is a mini mental state exam? It's a screening tool used to determine if the patient has problems consistent with the diagnosis of dementia. It is not used for suicide risk, autism, or aphasia. The optic nerve test. How do we make sure the optic nerve is working? First of all, it tests distant and near vision, and this is why we're using the ophthalmoscope during our assessments. We examine the fundi to make sure that that cranial nerve is intact. Define anosmia. That is a loss of the sense of smell or inability to discriminate odors. The olfactory nerve. What does it do and how do you test it to make sure it's working? Olfactory is in charge of smell. You close the patient's eyes, occlude one nair at a time, and then test with a familiar smell, like an alcohol wipe or something that you've prepared in advance. Spinal accessory nerve testing. What do we do? First off, we're going to test the trapezium muscle, and we do that by having the patient shrug their shoulders against resistance. So you put your hands on their shoulders. And then we're going to test the sternocleidomastoid muscle. You have the patient turn their head to each side against resistance. The glossopharyngeal and vagus nerves. How do we test them? What do we inspect about them? What do we observe about them? And how do we evaluate them? This is the glossopharyngeal and vagus. So first off, we are going to test the ability to identify sour and bitter taste on each side of the tongue. We're going to test gag reflex and their ability to swallow. Then we're going to inspect and palpate the uvula for symmetry with speech and sounds. Speech sounds, and the gag reflex. Then we want to observe for swallowing difficulty. And then we want to evaluate the quality of guttural speech sounds. All of those done at the same time. The acoustic nerve. We're going to test and compare it to what? We're going to test for lateralization of sound, the sense of hearing with a whisper test, and or audiometry, which we don't all have. And then we're going to compare bone and air conduction of sound with the Weber and the Rene test. The oculomotor, trochlear, then abducens nerves, test and inspection. Okay, so first we're going to test the visual fields by confrontation and extinction of vision. And we're also going to do extraocular eye movements. Then we're going to inspect to make sure that there's no eyelid drooping. We're going to check the pupil size and equality, pupil direct and consensual response to light, and accommodation. So this is the one that Perla is going to come into play with. That is the oculomotor, trochlear, and abducens nerves. The hypoglossal nerve. What do we inspect? How do we test? And what do we evaluate? Okay, So we want to inspect the tongue and while it's inside the mouth and while it's protruded for symmetry, tremors, and atrophy. The tongue movement to the nose and chin is also inspected. We want to test the tongue strength with our index finger when the tongue presses against the patient's cheek inside the mouth. And then we want to evaluate the quality of lingua speech, and that includes L sounds, T, D, and N sounds. Sites for deep tendon reflexes. Deep tendon reflexes can be found in the biceps reflex, the brachioradial reflex, the triceps, patellar, the Achilles reflex, and clonus. I have a handy-dandy mnemonic phrase to try to remember these. So it's the first letter of each one, and it was B, B, T, P, A, C. So I'm trying to remember it using Bye Bye Tupac. And those are the sites of reflex testing. So we're going to test it, but we absolutely have to know how to score it or we can't document anything. How do you score reflexes? So it's a 0 to 4+ scale. 0 is none, no reflexes. 1+ is a sluggish reflex. 2+ is an active reflex. So that would be your normal. 3+ is more brisk than expected. 4+ is brisk and hyperactive. And then remember that you are testing reflexes and comparing sides so that you know what's normal for your patient. What do absence of reflexes indicate, and what does hyperactive reflexes indicate? So absent reflexes can indicate neuropathy or a lower motor neuron disorder. Hyperactive reflexes can indicate an upper motor neuron disorder. Alright, here's an easy one. What is nuchal rigidity and how do you test for it? Nuchal rigidity is a stiff neck. It may be associated with meningitis or intracranial hemorrhage. We lie the patient supine. We slip our hands under their neck and try to raise their head by flexing the neck and bring the chin to the chest. If they have pain or if there's resistance, then that's a positive test. So what are two tests that may indicate meningeal irritation? The first one is Brudzinski's sign, and this is when you have an involuntary flexion of the knees and hips when you're flexing the neck. That's a positive sign. The next one is called Koenig's sign, and that is evaluated by flexing the leg at the knee and at the hip when the patient is supine, and then trying to straighten the leg. If there's pain in the lower back, that can also indicate meningeal irritation. What are Montgomery tubercles? These are sebaceous oil glands on the surface of the areola on the breast. They function to lubricate and keep germs away from the breasts. What can cause changes in Montgomery tubercles? Hormones, of course. Hormones during pregnancy, puberty, or menses. And then we have stress, hormonal imbalances, breast cancer, physical body changes such as weight gain or weight loss, medications, stimulation of the nipple, tight-fitting clothes or bras. Breastfeeding tips related to Montgomery tubercles. Do not wash the nipples with soap. Avoid non-breathable plastic lining in clothes and bras. If dry and cracking on the areola, then apply lanolin. What are some breast changes that happen during menopause? During menopause, your glandular tissue can atrophy, and that's replaced by fat. Yay! Breasts hang more loosely from the chest wall due to the relaxation of suspensory ligaments. You try to say it. Nipples become smaller and flatter, and there is decreased erectile ability. Okay, so the next couple ones are going to talk about common breast changes and abnormal breast changes. So common is just like normal breast changes with age. Those include stretch marks, downward pointing nipples, elongated, stretched, or flattened appearance of the breasts, wider space between the breasts, and lumpiness. Which should not be confused with the abnormal changes in the breasts, which include puckering, redness, thickening of breast skin, a pulled-in nipple, nipple discharge, breast pain, or hard lumps. Typical presentation of benign prostatic hypertrophy. Men 50 and older are a lot of your patients, but men 80 and older are still more of those patients. They're going to have lower urinary tract symptoms, and those can be broken down into two different categories. Storage symptoms, which means that they're having problem actually storing urine. So they have daytime frequency issues, nocturia, urgency, and urinary incontinence. And then they have voiding symptoms, so they have trouble actually urinating. Some of those include a slow stream, a spitting or spraying of urine, an intermittent stream, hesitancy, straining, and terminal dribbling. Risk factors for colorectal cancer that do not alter screenings. So these are lower level risk factors that don't need increased screening times for your patients. These include obesity, diabetes with insulin resistance, long-term consumption of red or processed meats, tobacco and alcohol use, androgen deprivation therapy, and cholecystectomies. Examination findings for osteoarthritis. Usually your patients are greater than 40 years old. They are usually obese, or they've had some joint trauma. They also can have a family history of osteoarthritis. They have asymmetrical joint pain that improves throughout the day. The joints involved are usually the hands, feet, hips, knees, cervical and lumbar spine. Cervical and lumbar spine, sorry. They can have Hebden nodes, which are hard, non-tender, bony nodules. They are 2 to 3 millimeters in size and located in the distal interphalangeal joints. They can also have Burchard nodes found in proximal interphalangeal joints. They have limited, painful range of motion to the cervical spine. They can have coarse to medium crepitus over their joints. Diagnostics include X-ray, which shows osteophytes and decreased joint space, and an increased sedimentation rate. Can you define osteoarthritis? Osteoarthritis is a deterioration of the articular cartilage covering the ends of the bones in the synovial joints. What are some foot and ankle abnormalities? Latin, pes varus, which is in toeing, pes valgus, which is out toeing, pes planus, flat feet, or pes cavus, high instep. What are 6 assessments that you can do on the knees and legs? The first one is ballottement. This tests for effusion of the knee. We extend the knee, apply downward pressure to the suprapatellar pouch with the thumb and forefinger, push the patella down into the femur, and then feel a tapping or clicking. An effusion usually is shown when the patella floats back upwards. The bulge sign is the next one. It tests also for effusion of the knee. We extend the knee and milk the medial aspect of the knee upward. If there's a bulge, there means there's fluid on the knee, which is what an effusion is. The next one is the McMurray test. This looks for a torn meniscus. We want the patient to lie supine, flex one knee, rotate the foot and the knee outward. It's a positive test if there's a click, any grinding, pain, or limited extension. The next one is an anterior-posterior jaw test. That tests for ligament integrity. The next one is the Lachman test. It tests for anterior cursicate, I'm not sure, ligament issues. The last one there is the Vargas and valgus stress test. It tests for medial or lateral ligament instability in the knee. We want the patient to lie supine, extend the knee. We're going to stabilize the femur and the ankle and apply force against the ankle. If there's a laxality of the joint, then that indicates injury. What are some hip assessments that we can do for our patients? 2. I need to write that on the front of the card. The first one is a Thomas test, and this tests for the flexion or contraction of the hip. We want the patient to lie supine, one knee extended and one knee flexed to the chest. Lift the extended leg off the table. And if they can do that, then they are positive for flexion contracture. And then there's a Trendelenburg test. It tests for weak abductor muscles. They stand and balance on one foot and then the other back and forth. And you observe from behind. If the iliac crest drops on one side, then the abductor muscle is weak. Thoracic and lumbar spine assessment. The first one is the straight leg raising test. This tests L4, L5, and S1 nerve root irritation. The patient lies supine with the neck flexed. They raise an extended leg. If they have pain below the knee, then that can mean disc herniation. If they have crossover pain, that can mean sciatic nerve impingement. The next test is the femoral stretch test. It tests L1, L2, L3, and L4 for nerve root irritation. We want the patient to lie prone and extend the hip. If there's pain, then that's a positive test. Okay, so the next one is temporomandibular joint assessments. The mandible should move 1 to 2 centimeters laterally. When you open and close a mouth, it should open 3 to 5 centimeters. When you test for this muscle, we want to clench the teeth and palpate the contracted muscles to assess the strength of the temporalis and the masseter muscles. And this is also a test for cranial nerve number 5. What kind of shoulder assessments exist? There are 2. The near test, which tests for rotator cuff injury or tear. We want to flex the patient's arm to 150 degrees while depressing the scapula. If you have shoulder pain, that's a positive test. And the second one is called a Hawkins test. And it also tests for shoulder rotator cuff injury or tear. We abduct the shoulder to 90 degrees, flex the elbow to 90 degrees, and then internally rotate the arm. If there's limb pain, that's a positive test. Hand and wrist assessments. There's the cat's hand diagram, which tests the median nerve. The thumb abduction test, which tests for carpal tunnel. The Tenel sign, which tests the median nerve. And the Phelan test, which also tests the median nerve. So, how do we assess muscle strength? Okay, not how do we assess it. How do we grade muscle strength, or how do we chart muscle strength? And it is graded from 0 to 5. 0 indicates that there's no movement. 1 is trace movement. 2 is full range of motion but not against gravity. 3 is full range of motion against gravity but not resistance. 4 is full range of motion against gravity, weak with resistance. And then 5 is normal. It is your full range of motion against gravity and against resistance. Palpate all bones and joints surrounding muscles for what? What are we palpating joints for? We're going to check for muscle tone, heat, tenderness, swelling, and crepitus. Those are the things that we can palpate a joint for. We're going to inspect muscles for what? We want to compare the sides for size, symmetry, and fasciculations or spasms. We want to inspect the skin and subcutaneous tissues over the muscles and joints for what? We're going to look at color, number of skin folds, swelling, and masses. We want to inspect the skeleton and extremities for what? Alignment, contour and symmetry, size, and gross deformity. What are some diagnostic criteria for rheumatoid arthritis? They must have 4 of the following. Morning stiffness greater than 1 hour for more than 6 weeks. Arthritis in 3 or more joints for more than 6 weeks. Arthritis of the hands for more than 6 weeks. Symmetrical arthritis of the same joint. Rheumatoid nodules or positive serum rheumatoid factor, or radiographic changes involving erosions or bony decalcifications. Diagnostics for rheumatoid arthritis. how do we diagnose this? We're going to check the sedimentation rate. We're going to check a CBC. We are going to check the normocytic anemia rheumatoid factor. And we're going to probably get an x-ray, and it's going to show bony erosion at the joint margins and joint deformities. What examination findings are you going to have for a patient with rheumatoid arthritis? This patient's going to have chronic inflammatory disorder of the synovial tissue surrounding the joints. That's the definition of the disease. They're going to be younger adults. They can have anorexia or weight loss. They have morning stiffness for greater than an hour, progressive fatigue 4 or 5 hours after rising. They have symmetrical arthritis. They have fever, rheumatoid nodules, or deviation of the wrists. They have spindle-shaped fingers. They can have medium to fine crepitus. The joints that are normally involved include hands, wrists, feet, ankles, hips, knees, and cervical spine. Name 3 spinal deformities. They are lordosis, which is found in obesity, pregnancy, and toddlers; kyphosis, which is over-curvature of the thoracic vertebrae; and scoliosis, which is curved from side to side. What is the purpose of the Denver 2 tool? This tool identifies young children with developmental disabilities. 4 domains of child development are personal and social, fine motor and adaptive, language, and gross motor. Mental status is the total expression of a person's emotional responses, mood, cognitive functioning, and personality. A mental status examination includes what? Physical appearance and behavior, state of consciousness, cognitive abilities, analogies, abstract reasoning, arithmetic calculation, writing ability, motor skills, memory, attention span, judgment, speech and language, and emotional stability. Peripheral neuropathy, subjective versus objective symptoms. Subjective symptoms include gradual onset of tingling, burning, and cramping, night pain, unusual sensation of walking on cotton, floors feeling strange, inability to distinguish coins by touch, and sensation of burning. Objective symptoms include decreased sensation in the foot, decreased sensation of pain and touch, decreased distal pulses, decreased or absent ankle or knee reflexes, decreased or absent vibratory symptoms below the knee, decreased temperature sensation, distal muscle weakness, and they're unable to stand on the toes or the heels, skin alteration or injury that the patient is unable to feel. Alright, so We talked about risks for cancer, colorectal cancer earlier. These are the high risk factors, the ones that are going to alter your screening process for your patients and make them come more often and get more things done. These risk factors are all hard to say, and they include familial adenomatosis polyposis, Lynch syndrome, Muth-associated polyposis, hereditary breast and ovarian cancer syndrome, personal or family history of sporadic colorectal cancers or adenomatosis polyposis, irritable bowel syndrome, ulcerative colitis or Crohn's disease history, cystic fibrosis. African Americans and men are more likely to have colorectal cancer. People with a renal transplant or diagnosis of acromegaly are more likely to have a colorectal cancer. Alright, so examination of children with heart murmurs during a sports physical. What do you need to know? First of all, we need to note the location, the grade, and the radiation of the murmur. We need to know that loud murmurs are best heard in the upper right sternal border or the upper left sternal border. A thrill may indicate a congenital heart defect. Structural heart disease may be present if they have a holocystic, diastolic, grade greater than 3 murmur associated with a click. It increases with standing or is a harsh murmur. Still murmurs are innocent murmurs that are resulting from vigorous contractions. They may disappear with changes in position. Remember that you should auscultate supine and standing or with a Valsalva maneuver. What is schizophrenia? Schizophrenia is a severe persistent psychotic syndrome with the